Pod.
Hello, I'm Ruth Bowen. I am the BNSSG Child and Young Person Education Fellow for the Training Hub. And today I'm at Bristol Children's Hospital with Nick Sargent. Nick, would you mind introducing yourself?
Yeah, hello, I'm Nick Sargent. I'm a consultant in both paediatric emergency medicine and paediatric allergy, and it's the latter I'm here speaking to you about today.
Thank you. And today we're going to be having a conversation about cow's milk protein allergy. We'll start with a case and then we'll go through a few questions if that's all right.
Of course.
So our first case, both parents present with 3-month-old Rupert. Mum is feeling at the end of her tether and wants to know if something's wrong. Feeding has been a battle with Rupert coming on and off the bottle and has been vomiting up to half his feed within a few minutes after every feed since he was around 4 weeks old. He arches his back and seems distressed. It happens throughout the day but is worse in the evening and overnight. He does have settled periods between feeds, but Mum describes him as a fussy baby who cries a lot. There's no history of haematemesis, bilious or projectile vomiting. Rupert has plenty of wet and several loose, dirty nappies per day, without straining or blood. His weight's dropped from the 75th centile to the 50th. There were no complications of pregnancy, delivery at term, or the postpartum period. And apart from persistent moderate eczema, Rupert's been fit and well. Would you mind chatting us through this case and what your approach would be?
Yeah, of course. When you start looking at these cases, generally speaking, families are already orientated to the idea that their child might have a milk allergy. And by that I mean a delayed or non-IgE mediated milk allergy based on that history. But I think you've always got to put the brakes on a little bit and acknowledge that 60% of babies have reflux. Many babies have loose mucousy poos just as normal, and many babies have eczema as normal. So it's important to work with the families and not alienate them, but it's also important not to jump too quickly to a diagnosis of cow's milk allergy if there isn't enough evidence for it. And generally speaking, I kind of subdivide these babies up into 3 domains. I look at their upper GI tract, their lower GI tract, and their skin. If they've got involvement in all 3 of those areas, so an uncomfortable, refluxy baby that is really difficult to settle and is making everyone's life a misery, not least their own, allied to loose green mucousy, sometimes bloody, but that's very rare, stools, and significant eczema, I'd be more likely to go down a let's try exclusion of cow's milk earlier than later. But if I've got a family that are coming in with really only a problem in one of those domains, upper GI, lower GI or skin, I'd be much more inclined to go several steps up whichever treatment algorithm you're using for either reflux or eczema or just reassurance with the lower GI symptoms than going down a cow's milk exclusion straight off the bat. That said, you sometimes have to play the man rather than the hand, as they say, and if you get a sense that family are just going to go away and exclude cow's milk, it's important, I think, to acknowledge that and work with them around that, because if that's where they're going to go and do it. And the danger with that, if they're not working with you and they don't feel like they have an open dialogue with you, is when the cow's milk exclusion doesn't work, they're going to go down a soy exclusion, wheat exclusion, an egg exclusion, and it carries on. And then you can get these families that have gone into multiple exclusions without any really good objective evidence for an improvement. And that can become a bit of a mess, not least because nutritionally, the mum is excluding herself and then breastfeeding the baby. The mum's health you've got to worry about, let alone the baby themselves. That's how I would approach it. So if a child does have evidence of significant worsening of their upper GI, lower GI and skin symptoms in relation, and mum, if she's breastfeeding, being able to convince herself that when she consumes a lot of milk herself and then breastfeeds the child, these things are considerably worse, I'd be inclined to go down a cow's milk exclusion thing quite early, but put some guardrails around that. Say, we're going to exclude for 2 weeks, then I'm going to see you again. And you're then looking for a clear benefit from that exclusion. I tend to say to the families, if you're looking at your partner and going, do you think he's a bit better? What do you think? And you're having that conversation, that is not the benefit. You see a frame shift. It is everything's better. But I also warn them that you're unlikely to get rid of all of the symptoms. Because 60% of babies have reflux. The baby probably did have reflux anyway. It was that the cow's milk protein allergy was making it worse. Likewise, the child probably has eczema anyway, but it's the cow's milk allergy that's making it worse. It's important to set expectations. It's important to help them navigate that. And it's important to come to an agreement that if after 2 to 4 weeks. There is either no improvement, you're going to reintroduce milk and then assess whether there's actually a deterioration with that. Or even if there is improvement, you've tried to negotiate that you will ask them at least to try putting milk back into the child's diet again to see if there's a deterioration. Because that exclusion, improvement, reintroduction, deterioration locks the diagnosis down. Mm-hmm. And once you've done that and you can convince yourself that, that's how you make the clinical diagnosis. Now, that's not to say there clearly are some babies that their eczema alone is interfacing with cow's milk allergy, but I wouldn't be as quick to go down a cow's milk exclusion line. With eczema, I'd probably get them up to low-dose topical steroids before I went, well, let's try exclusion of milk. And likewise with reflux, I would probably have got them up to omeprazole before I went, okay, let's try cow's milk exclusion if there's essentially a single organ system involvement. Does that kind of make sense?
So it's just less convincing once you got that algorithm first. And you said 2 to 4 weeks. Is that a good time period to be thinking about when you do the exclusion?
Yeah. If they've truly got a delayed or non-IgE mediated cow's milk allergy and you adequately exclude cow's milk from either the baby's diet or the mum's diet, I'll come back to the latter in a moment, you usually see a benefit in 3 to 4 days. I tend to say about a week to 10 days to the families because actually often these are breastfeeding mums and often actually it's hard to work out where the little bits of cow's milk get into your diet. Because if you're not tuned to looking at, I don't know, ham that maybe has breaded coating that's got cow's milk in it, or various other foods that actually cow's milk is a very small component. If you're not tuned into that, then it can be hard to completely nail it down. So it is important to provide the family with advice on how to exclude cow's milk from their diet and provide them with a little bit of support about that. In a clinic, in a hospital, of course, we come at this not always, but often with the advantage of having a dietitian. But most of the time, you don't need a dietitian as long as you can help the family understand the process.
Okay, thank you. Is it as common to get cow's milk protein allergies in breastfeeding mums?
So I think this is actually something where I detect confusion in clinicians that refer to us. Yes, it is, but in the domain of delayed or non-IgE mediated allergy, not in the domain of immediate allergy. That's a bit of a distinction because I think some people just think, oh, allergy, and then I get a lot of referrals around immediate or IgE-mediated allergy, which I think we may be coming to shortly. And actually, they're talking about the child reacting to breast milk or not. In my 15 years of doing allergy now, have yet to ever be convinced of seeing an immediate or IgE-mediated allergy to a food protein transmitted through breast milk. But in the domain of delayed or non-IgE-mediated allergy, it absolutely happens, but it tends to happen with milk, sometimes soy, other foods, egg, nut, aubergines, butternut squash, or other foods. You've really got to question because that is incredibly unlikely. Almost always there's a better explanation. Usually the child has intrinsic eczema and probably just handling these foods and then handling the baby is causing intermittent flares of their eczema. And I think it is also important just to push back sometimes with these families and be very clear, particularly with eczema, that their eczema is intrinsic. The cow's milk allergy may be making it worse, but when they're in nursery and surrounded by kids with coughs and colds and are rolling around in messy play and are getting hot and sweaty, their eczema is going to flare and it isn't necessarily an allergy.
That's really helpful, thank you. So with a case like Rupert, where we've got the triad of the upper GI, the lower GI and the skin as well, is there more that you would want to know in the history? Are there any particular red flags that you would be looking for?
I would always want to know what the weight gain's like. I noted that he dropped from the 75th to the 50th, which in itself, you've always got to look at trends and where he was before that, but you'd want to be switched onto that and continue to monitor it. I don't think that requires an intervention that moment, but you want to continue to track it. You do need to examine the baby and make sure that their abdominal examination is normal. Then following through the algorithm we were talking about of exclusion, but then reassessment and reintroduction.
You've touched on this already a little bit, but are there any ways that you distinguish between gastroesophageal reflux and cow's milk protein allergy? So if we're looking at those ones where they haven't got that triad, so you've already mentioned that if they've got lower GI symptoms, skin symptoms, that's starting to push you more towards the cow's milk protein allergy. If it were just upper GI, how would we know?
That is the hard thing about this world, and sometimes you just have to be really honest with yourself and the family and go, the only way we're going to know is a bit of trial and error here, and then you pragmatic, and that word pragmatic is central to allergy medicine really, and I imagine to most of primary care is the honest answer. I explain this all to the families. I say, look, I'd be much more confident in the diagnosis if all of this was happening. It isn't. Doesn't mean that it's not a cow's milk allergy problem, but my preference would be for us to try going up the reflux algorithm first before we start excluding foods from yours or the baby's diet. What do you want to do and where are you? Because if they're going to go away and do it anyway, you may as well do it together and then go down. I'm not a big fan of Gaviscon. It almost always causes the baby to become constipated, and I'm never convinced it's the most beneficial medicine out there. But whatever your approach to managing reflux is, I tend to jump straight to positional advice and then omeprazole.
Thank you. So with Rupert, how would you manage him?
I think with this baby, I would, assuming that we've decided together that we are going to explore the cow's milk allergy side of things, I would say to them, first of all, I do want you to carry on with whatever treatments you've already been given for reflux or eczema. This is not a substitute for those, it's to work in unison with them. If we're right, we may be able to reduce those treatments, but it may well be that Rupert still needs to have some emollient cream, some omeprazole. We don't know until we've tried it. I would then, if mum is breastfeeding, orientate her to what a cow's milk-free diet looks like, ideally provide them with some information about that. And then I'd warn them that you're not going to see an immediate benefit. We need to give it a week to 10 days to see if there is a benefit. If after 2 to 4 weeks you have not seen a benefit, and I talk to them very much about a frame shift, you've not seen a considerable benefit, put cow's milk back into your diet and then keep a diary of what that looks like with the baby. One wonderful family once, who were both scientists at the university, decided that they were going to do a blinded trial, that one of them would start giving the child milk without telling the other one to see if they noticed the difference. Most families won't ever work at that level of rigour, but you try to give them the toolkit to be able to unpick it. But it is important to try and get them to agree at the outset that they will reintroduce milk, regardless of whether there's a benefit or not, to see then what the result is. We don't need to be punitive about this. If you've seen a benefit and then you give them milk again and you see within a bottle of milk, or mum consuming yogurt for the first time and then breastfeeding, deterioration in the baby, you've kind of proven your point. And then you can go back to cow's milk-free diet, and then you put them in a position of stability really then until about the age of 1 year, and then you start thinking about reintroducing cow's milk using the cow's milk ladder.
So is that when you would start thinking about reintroducing it, is around about a year?
Yeah, I mean, it works out that way. You could, in a family that were really motivated and really interested, do it after about 6 months. So if you're likely to see them in primary care quicker than we do, because just by the nature of getting through the referral system, I rarely see a baby with this sort of thing before 6 months of age. I suppose if you're seeing them at 3 or 4 months and making that diagnosis, you could consider the cow's milk ladder at 9 or 10 or 11 months. There's no reason not to, but it's just pragmatically, it often works around 1 year of age.
And you mentioned dietitians and you having easy access to them. In primary care, at what point should we be referring for dietitian support?
Certainly, I think if you've got any worries about weight gain or nutrition, that would include mum as well, in terms of mum's diet and wellness from a nutritional point of view, weight gain of the baby. Or if you're going down a line of, rightly or wrongly, the family may be pushing this agenda, even if you're not completely in agreement, excluding more than one food. Having dietetic support at that point is really, really important.
Okay, so it is more the high-risk cases rather than you wouldn't be routinely doing it for every child once you've excluded, reintroduced and confirmed that this is looking like
I would love to be able to, but there just isn't the dietetic resource to do that, yeah.
Fine, okay. And we've talked a little bit about excluding milk. So for Rupert, he's bottle fed.
Okay.
What will we be doing for him?
So in the domain of delayed or non-IgE mediated allergies, the first thing you try is an extensively hydrolyzed formula. I'm not going to name brands. There are many in the market. To my mind, there's no one that's better than another. And it's really about palatability and what the baby gets on with and what the family gets on with. This domain of allergy, the delayed type allergy, are the ones that quite frequently need to go to that extra step of going to an amino acid formula. Because actually, weirdly enough, although this is not the more dangerous type of immediate anaphylaxis type allergy, this type of allergy is the one where they're reacting to tiny amounts of cow's milk sometimes, and they can have problems. So these are the ones where you may need to go to one of the amino acid formulas. Again, several on the market. Again, I've got no massive preference as to which one.
So would you always try the extensively hydrolyzed first, and then if that's not sufficient, then building it up to the amino acid after that? Perhaps
the one group I might maybe defer from that are the ones where they have got real thriving problems and you're really worried about them. They're really scrawny, they've lost a lot of weight, and perhaps there has been a sense that mum has tried exclusion if she's been breastfeeding before and it didn't really work or something like that. Then I might, to get control, go straight down into an amino acid formula, but 9 times out of 100 you'd start with a hydrolyzed formula. In the context of primary care interaction, you'd always start with a hydrolyzed formula. And what you tend to see is some benefit for a few days and then the symptoms seem to come back if it's not going to work, or limited benefit. And if you're kind of going, well, it was a bit better, but it's still pretty bad, then the next thing to do is to try an amino acid formula. If the families are still like, things are really, really bad, and there's a sense you get, and I know that's a really hard thing to do, that just everything is just a bit worse than the average. The reflux is worse, the stool problems are worse, the skin is worse, and you've not seen a benefit from the extensively hydrolyzed formula, then it's still worth, I think, then trying an amino acid formula. But again, you've got to go on the journey with them, because if at the end of that, that's not worked and they've really done it properly, then we're barking up the wrong tree, and we need to go back to treating the symptoms in front of us, the eczema, the reflux.
Again, would you be thinking 2 to 4 week trials?
Yeah.
Is that your ballpark there?
Yeah, so it's a good rule of thumb. 2 to 4 weeks is a good idea. Yeah.
And presumably, does that guide how often you'd be suggesting that we follow up in primary care? So should that be every 2 to 4 weeks, depending on our level of concern?
Yeah, I think so. Some families need holding closer than others. In this world, there are some very anxious families and there's some less anxious families. You've just got to take the temperature and try and work with that family as best you can.
And you said that you would try reintroducing about 12 months. Does that give us any hint as to what the likely progression is going to be? So when parents ask us, are they going to have this forever? Are they going to grow out of it? What should we be advising them?
Well, we say that most allergic disease in both domains, you say about 80% of babies will outgrow their allergy with time. Admittedly, I'm seeing a slightly different group to the ones you maybe see, often the ones that end up in my clinic. I've got the slightly more persistent delayed allergy in combination with immediate allergies. If you're still having conversations when they're getting to 18 months, 2 years, I tend to then have a conversation which goes along the lines of, we all know friends and adults that have got a cow's milk intolerance. It's a spectrum. I hope that with time, Rupert will be able to have milk in his diet normally, but he may be someone that cannot or can have a little bit. I talk about a bit in his tea and his coffee when he's older and a bit on his cereal, but if he has milkshakes, that's just a step too far to him. And the important thing when you get into that kind of place is to be able to say, look, just periodically, every 3 months, try and increase the amount of milk. Do it at a time that isn't going to disrupt key life events. Don't ruin a holiday. It's all right to take a break and just go, we're not going to do anything for 6 months and then have another go. But it's just important periodically to retrial it. Just got to pick out the families that are just not going to do anything and help, because there are nutritional consequences, just lots of food exclusions, usually multiple food exclusions. But the reality is, if it's only cow's milk and they're over 1 and they've got a broad and varied diet, they're not really nutritionally compromised. So you can be pragmatic.
Brilliant. And we know that there's an overlap between cow's milk protein allergy and soy allergy. Is that something that you mention to parents?
Yeah, sometimes. Again, take the temperature as to whether it's a good idea to alert them to a worry, and then confirmation bias means that they then come around and go, oh, it is a problem, or not. But most of the families, to be honest, have worked this out for themselves. They've gone online. I usually talk about it. We talk about 30-40% of kids with a confirmed delayed type cow's milk allergy may have something similar with soy. Usually not severe, and they usually can tolerate some soy in their diet. Usually the breastfeeding mum can still eat bread, small amounts of soy in pre-packaged foods. But maybe if the mum is vegetarian herself or something like that and has a lot of soy in her diet, you may see that tip over the edge.
Perfect, thank you. And then just to wrap up this case, talking about reintroducing milk and following presumably the IMAP ladder, is that the one that you use here?
We have a variant of it, but the IMAP ladder is entirely reasonable to use, yeah.
Is that the one that you'd recommend in primary care?
Yes, for the delayed type allergy.
And if there were a soy allergy as well, how would you advise parents to do those 2 ladders alongside each other? Should they be alternating one than the other, doing it based on which one is worse? What's your usual strategy there?
Find out which food is more important to them. It's usually milk, and I tend to suggest that they do one at a time. The reality is, it's rare that you need to be too regimented about reintroduction of soy. The place it has in our collective diets means that for most families, it sort of organically seems to come back into many of their diets. Milk is where you spend most of your time talking in these
Milk
cases.
is the more regimented one in reality. Okay, thank you. So if we go on to our second case, Mum brings in 7-week Alba to her GP. She was previously exclusively breastfed, but they've recently started mixed feeding. The last 3 consecutive feeds, she's noticed hives, a post-feed nappy change. The rash settled over the last 2 hours, so there's now nothing to see. What else do you think it would be important for the primary care clinician to ask about in this case?
It's always important to be really clear when you're assessing for an immediate type allergy for a few things. You're looking for an exposure to a known allergen. In this case, it's fairly clear that we're talking about milk. But you also want to be sure that it is only milk. There's not something else, peanuts, egg. You just got to think about the other common allergic foods. And what are those? Milk and egg, by far the 2 commonest foods, followed by peanuts, followed by tree nuts, with sesame, and then fish and shellfish. Broadly speaking, those are your allergic foods. Soy as a cause of an immediate type allergy, really very rare. You want to make sure that there's not another likely allergen. You've got to look at the time frame and try and be as exact as you can, because most immediate type allergies, you're starting to see symptoms and signs within 10 to 15 minutes. At the outside, it's an hour, but it's 10 to 15 minutes as a rule. If you're starting to get a repeat history of only picking up hives or whatever the symptoms are after 30 minutes, the hour, you've got to question whether this is actually an allergy or not.
So we need to know when these nappy changes are.
Yeah,
exactly.
So be really clear on the time frames, as clear as you can be. You also want to look at reproducibility. Is it happening every time the child consumes that foodstuff, in this case milk? Are there times that they're having milk and not having the symptoms? And that's something you don't always ask. And the families are so tuned in, oh, we've had these. They don't sometimes think, well, actually, we gave them cheese as well, and that seems to be fine. It's important to look to see if there's reproducibility, both in terms of symptoms and also not having symptoms, if that makes sense. So that's the next thing. And then you're looking for any other symptoms, because at the moment with this little one, we're just seeing hives. In this age group, there are at least 2 more likely reasons for a child to have hives than allergy. There's this misconception that hives mean allergy. In this age group, hives as likely mean a viral infection. It can be just because they've got sensitive or eczematous skin and it's got a bit inflamed. So it's important to look to see if there are any other symptoms. Because most allergic reactions, they may also be a bit congested, rubbing their eyes or sneezing, vomiting, or later on if they've actually swallowed it and not vomited it, diarrhea. So it's important to look for those other symptoms. You don't wish a child to have more symptoms of allergic reaction, but if they are there, that makes the diagnosis more likely.
So how would you approach this case? What would you do now?
If you confirm that, so let's make an assumption that these nappy changes are happening very quickly, or they are looking because the child's a bit unsettled. So we're seeing that reliably we're having symptoms within 10-15 minutes on 3 separate occasions. If also the child then you find out had a vomit or 2 and some hives elsewhere, those kind of things, that is an immediate or IgE mediated allergy. And you don't need testing. The testing in this context, and by testing I'm talking referral for skin prick testing, is more as a way of them mapping the allergy and deciding when to reintroduce the milk later on. If I was seeing them in clinic and I skin prick tested them, they may have a 6mm wheal, and then I can see them again in a year, and if it's gone down to 2, I'm guiding introduction of baked milk and then other milk.
That's so interesting. I didn't realise that it was predominantly around the management rather than the diagnosis.
But of course, if this was the first time they'd eaten egg and milk, and I know it would be unusual to also have peanuts in there or cashews or something like that, and they immediately had symptoms, you would be using it to help you work out what they're allergic to. Mm-hmm. So skin prick testing is by far and away, I think, the best way of doing allergy testing. And those of your eagle-eyed listeners will note, if they've looked at the food allergy guideline recently, we removed all reference to doing specific IgE testing from it. And that's because we don't think that specific IgE tests as a first-line allergy investigation are always helpful. And there's always a danger, because the family are with you there, oh, we'll also just do the mixed food rather than just the test to milk. And then the mixed food panel comes up with slightly positive result to soy, even though they've been eating soy and they're absolutely fine. The next thing we know is there's unnecessary food exclusions. And sometimes there's a consequence to that, because if you actually then exclude those foods unnecessarily, the child goes on to get an allergy. So it is important to be really focused about what you're doing, and everything comes from a good allergy focused clinical history. There's this thing called the eater's history, which everyone can find on the local food allergy guideline, but the most important bits are the speed of onset, reproducibility, and the framework of symptoms they have. The more the merrier in terms of making a diagnosis. The other really important bit is to explore this child's personal atopic history. The vast majority of children with immediate type allergies have eczema, and it is the eczema we think is the cause of their food allergy rather than being caused by. Okay. And that's a frame shift that most families find when you talk to them. They find it quite, oh really? Why are children reacting the first time they eat peanut or eat sesame or eat milk? It's because they've been exposed through the skin. And if you've got eczema, you're more likely to have exposure to the deep dermal layers presenting to these things called dendritic cells or other immunological cells, and you get this exaggerated inflammatory response, which is allergy. Whereas we know that early introduction via the GI tract is more likely to promote tolerance, and there's really good evidence for that, particularly for peanut, particularly for egg, but there's certainly no harm in doing it for the other food. If you've seen any letters from our team recently, you'll notice that we're very passionate about promoting early introduction. There's good advice about that from the British Society of Allergy and Clinical Immunology you can find.
I'm well aware about the shifts in early reintroduction, but I'm really interested about the eczema element there.
It's been a view that most of us have had, and most allergists will talk about. It's not the only route of sensitization, but in the context of these preschool children, it is.
It is a route. That's so interesting.
And that's what most of us believe and think, and there is reasonable evidence for it. It's not conclusive. We do see some babies that have not had significant eczema and have allergies, and we don't know quite what the mechanism is for that.
Interesting. So with Alba, we're thinking it's an IgE-mediated calcium protein allergy. What would you want the primary care clinician to be doing with her at this point?
So, and remind me, how old is Alba?
She's 7 weeks.
7 weeks. So in this case, it's absolutely fine for mum to continue breastfeeding this baby, and mum can continue to consume cow's milk. Doesn't need to exclude cow's milk. But she, of course, needs to not be consuming cow's milk whilst breastfeeding or having milk that the baby can get their hands on. But in terms of passage of an allergen through breast milk, this isn't a thing. There are case reports of children having more immediate allergies to food proteins in breast milk, but as I say, I've not, and nor have my colleagues, none of us have ever seen it in reality, so it is vanishingly rare. So there's no need to advise mum to avoid milk. But if mum wanted to stop breastfeeding and bottle feed, you would start with an extensively hydrolyzed formula.
So now that she's mixed feeding, you'd say she can carry on having milk in her diet, but she needs that extensively hydrolyzed formula instead of the formula she's currently using.
Yeah, absolutely. And most of these kids with an immediate type allergy are absolutely fine on an extensively hydrolyzed formula. It's very rare that you'll need to go to an amino acid formula in this domain. Bear in mind, though, that some kids do have an element of both non-IgE mediated and IgE mediated, which is
just
a whole level of complexity that we perhaps don't need to touch on today. And they tend to come to us for management. But yeah, no, they should be fine. At the moment, they do need referral because we do want to do that skin prick test. And that will help us guide when to introduce milk back into the diet. You shouldn't be kind of embarking on cow's milk ladders with this immediate type allergy without that information. With time, there's a possibility that might change. For example, egg allergy, got a good clinical diagnosis and they've not had breathing problems or anything more than skin or GI symptoms. We don't need to do skin prick tests to guide management. We know that they pretty predictably will be able to introduce baked egg after 6 months, but with cow's milk, we still do want to see them and we want to do a skin prick test. And I think it's important to provide context. Yes, the vast majority of children with an immediate or IgE mediated allergy outgrow it, and most of the time the reactions are relatively mild in this age group that we're talking about here. However, cow's milk allergy is still the leading cause of death from anaphylaxis in the UK. We don't need to scare our families, the vast majority of them are going to get better, but we also need to just be a little bit guarded about how we manage it.
So on that note, we shouldn't be reintroducing before they've been seen by you in clinic and be guided by you on that.
Yeah.
And what would be our indications for sending them straight to A&E?
If at any point the child has breathing difficulties or evidence of cardiovascular compromise, usually that's they become lethargic or floor pale, you're advising them to call an ambulance, or if they're in your practice, that's when you should be giving adrenaline, and that's when you should be calling an ambulance to scoot them over to my other place of work in the emergency department. Yeah.
And is there a similar prognosis for IgE-mediated calcium protein allergy to non-IgE?
Yeah, they both. In fact, probably slightly better, I'd have thought, just anecdotally, but we quote 80% kind of resolution for both. My experience is the immediate ones are the more likely ones that they will outgrow it. We do use a cow's milk type ladder or a reintroduction advice leaflet for these children out of clinic, but that's after we've made a diagnosis, got skin prick testing, and are making a decision when to use it. And I think sometimes that causes confusion because people conflate the two types of allergy and go, oh, well, we can just do that with a ladder here. A reality is that milk is a really, really common allergen. And in primary care, whilst they're waiting to see us, you may diagnose and refer them. And unfortunately, our waiting times are too long at the moment, and we're trying to do something about that. But then at the age of 9 months, this child eats a multi-milk biscuit or a digestive biscuit off their parent's lap, and they're fine with it. Well, in which case, you can use that information, use the accident information to be able to go, well, okay, you can start introducing more foods that contain baked milk whilst you're waiting to see the allergist.
At that level of the ladder.
Exactly. Don't go beyond it.
Very logical. So moving on to a third case, just to think about a common differential. 12-year-old Jamal reports fever, diarrhoea and vomiting 3 weeks ago. The fever and vomiting settled after 2 days, but Jamal has ongoing intermittent abdominal cramps and diarrhoea. Worst in the morning, variable through the day, and generally he's fine at night. There's no blood and no history of foreign travel. The primary care clinician has done a stool MCNS, which is normal. What would you be thinking about here? What might be causing this?
The most likely thing here is a lactose intolerance, an acquired lactose intolerance, and that often happens after they've had relatively trivial viral illnesses involving the GI tract. If you get to 10 days, 2 weeks after that illness should really have settled, and they've got watery, loose poos, often with a lot of flatus and bloating. But it's usually that lower GI domain by itself. If you think this could be a lactose intolerance. And in the old days, they used to try stool reducing sugars, total palaver, to try and get those done. You never got them done in time. There was no hope of primary care ever getting them done in time. We could barely get them done from the emergency department in time.
And they're pretty redundant by the time you're back.
Absolutely. Yeah. So what we tend to do now is just let's go lactose free and assess the response. And again, use that 2 to 4 week thing. You should see a good response in 2 to 4 weeks. And if you then see a response, then I say to the families, it's a made up number that I use. Let's do it for 3 months. And then after 3 months, reintroduce foods containing lactose. And I always warn them that when you reintroduce those foods, you probably will see they're a bit uncomfortable, their stools loose and a bit more windiness, but persist for a week or two, because actually, usually it's just getting that equilibrium back. If after a week or two they're really, really bad still, you may need to take them off lactose again and wait another 3 months and try again.
How would you explain it to families? What's happening here when they've got this acquired lactose intolerance?
Celia and Billy on the brush border have just been traumatised by the viral illness, and you need to give them a break and let the enzyme regenerate basically so that they can cope with this. I keep it as simple as that. All forms of lactose intolerance are slightly more common in certain ethnic groups, Southeast Asian group, but you see it in all ethnicities. It's a really common thing that we see, and you can usually diagnose it by being pragmatic. It's probably a useful time just to reflect on terminology around all of this, because we do get a lot of things where the words lactose, cow's milk, dairy all get used interchangeably. It's important to just get terminology right, because of course lactose free still means you can have cow's milk protein. But,
sugar, not a protein.
Exactly that. Yeah, that does sometimes get lost with the families. It's important to explain that to the families.
And this is an acquired lactose intolerance after a gastroenteritis.
Yeah,
are there other mechanisms by which patients can be lactose intolerant?
There are primary lactose intolerances, really quite rare. I don't think I've ever seen one. I'm sure our gastroenterology team do have them on their books. And as we talked about, there are certain ethnicities where just their tolerance for lactose is less than it is mine, for example. Again, a threshold with those, they can tolerate some lactose. It's just they're not going to have loads in their diet. It just doesn't agree with them.
So we've thought about calcium protein allergy and divided it into IgE mediated and non-IgE mediated. And then you've also touched a bit on reflux as a differential, lactose intolerance. The last one I just wanted to ask you briefly about is colic, because there can be a lot of confusion from clinicians and families alike about colic. What is colic?
Who really knows? Diagnosis of exclusion, so you want to make sure they've not got anything more serious, and by that you're looking to make sure they're thriving and make sure they've not got any obvious pathology. Is it that their gut flora is just getting used to the world and producing more wind? Is it just that they're learning to coordinate their peristalsis? No one really knows, but from bitter experience of one of my own children, it certainly really is a thing.
Yes.
Be sympathetic to families. Whilst in the long run, it's a trivial thing. At that point, when you're getting no sleep and the child's screaming, and it is everything in your world at that point, and it's important to acknowledge that and hold these families a little bit and don't trivialise it. Look for the reflux. It usually starts after a couple of weeks, gets worse sometime between the 6-week and the 3-month mark, and then usually does start to improve. If we go back to the delayed type allergy, colic symptoms, if you've got a delayed type allergy, are worse as well. But what are those symptoms? Was it colic in the first place, or was it that there was inflammation in the GI? Who knows?
So it can be quite hard to depict them all apart.
Yeah.
And I also understand parents often talk about the witching hour as well in the evening, where it very much builds up. Possibly, maybe, because gas is accumulating and it's stretching the bowel more and it relaxes overnight. I don't think we really know.
Or is it just that the point that everyone wants to slow down and stop, and then the baby doesn't? Who knows? Who knows? But yes, again, just from bitter experience, I remember the witching hour vividly. It does seem to be a pattern. It's real, but you just got to be really reassuring with the families. But be on the lookout, on a serious note, though, the families that are not coping. These babies with really difficult reflux and babies with nasty colic, unfortunately, are at increased risk of harm from non-accidental injury and just people at the end of their tether losing control. Remember that component.
On that note, there's the fantastic resource that's been developed called ICON that we can send to families, which is basically an acronym, the I standing for infant crying is completely normal. So just talk to them about it, normalise it, support them. See, comforting methods can help. So simple things like taking your baby for a walk, cuddling them, singing to them. Oh, it's okay to walk away. When things are really building up, it's all right to put them down. You know they're safe. Go away, have a cup of tea. There's a really powerful video on there about a dad that's really struggling, and N, never ever shake a baby. So that's a really good one that you can send to parents if you think they're struggling to cope.
Yeah, it's a fantastic thing. And just telling them it is okay to walk away. I bet a crying baby is only a crying baby. It's not going to come to harm. Walk away. I think that's quite powerful. Yeah.
Are there any other resources for parents with children primarily with cow's milk protein allergy that you'd like to highlight?
The Allergy UK website I'm a big fan of. They've got resources there for pretty much all of the allergy stuff, and I think it's a very balanced website. The anaphylaxis campaign has also got some very good resources. Perhaps tends to cater to people at the severe end of the allergy spectrum. For some of the more mild allergies, I do worry sometimes that some of the stuff there might be a little scary. So I tend to point people just from personal preference towards the Allergy UK stuff first of all. And then the British Society of Allergy and Clinical Immunology's website's got some really good stuff about allergy prevention and early introduction of foods with allergy.
Fantastic, thank you. And what would be your key take-home messages for primary care clinicians?
Common sense. Sometimes it's just about following the lead and just pulling the thread and doing a bit of detective work, but just common sense. There's always more than one way to unpick an allergy thing, and you've got to work with the families, and just common sense and pragmatism, those two words. Don't worry too much about getting it exactly right or following an algorithm. Sometimes you just go, you've got the building blocks that we talked about today, and just work with the family and find a route with them to explore it. And when they're ready, pushing them a little bit, but also just allowing them to explore it at a pace that suits everyone.
Brilliant, thanks. And I think for me, a couple of the key take-home messages from our discussion is that triad of, in cow's milk protein allergy, looking at the upper GI, the lower GI and the skin. And I think that can be one of the helpful ways of distinguishing between reflux and cow's milk protein allergy. Being able to be sensitised to allergens through eczema. So that's not something that I was aware of. It logically makes sense.
Cutaneous exposure, and it's just more likely with eczema. Yeah.
And that IgE-mediated cow's milk protein allergy through breast milk is actually really, really rare. So mums where we're talking about IgE-mediated, they don't need to expose the cow's milk protein from their diet. It's just formula change that we're looking at there.
Yeah.
Brilliant.
Lovely.
Thanks so much.
Thank you.
The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen and interviewees are not liable for any clinical decisions made as a result of this podcast.